Periodontal treatment involves diagnosing and correcting diseases of the supporting structures of the teeth. These include the bone, the ligaments that run from the bone to the teeth, and the gums, or the gingiva. The severest forms of periodontal disease, once called pyorrhea, result in loosened teeth, infections, and bone defects that make cleaning difficult for the patient and can even lead to tooth loss. Regular dental checkups and cleanings and daily brushing and flossing virtually eliminate periodontal disease, while there will always be situations where unusual dental anatomy or genetic conditions can cause periodontal disease. Even in the presence of optimal professional care and home care, dentistry is moving towards the elimination of periodontal disease. Before discussing the disease, let's remember our professional role in preventing it. In dentistry, we have motivated and taught patients healthy habits so successfully that by some estimates, 1/2 of the American population regularly sees a dentist. Now that's a record that the medical community strives for. Generally speaking, there are 4 types of periodontal procedures. The first is preventive care. This involves patient education and regular scalings and polishings, which we've all experienced. Preventive care takes up most of the dental hygienist's time. The remaining types of procedures involve treating active disease. The goal is to recreate bone and gum shapes that allow proper patient home care. In cases where there is very little or no bone loss, and periodontal measurements around the teeth show pockets less than 5 millimeters, the disease may be arrested non-surgically. Typically, the dentist or hygienist scales the roots of the teeth in a procedure called root planing. If minor diseased tissue is present as well, curettage is used to remove it. Finally, the teeth and the roots are polished. In cases where there is bone loss and pocket depths more than 5 millimeters, preventing the patient from effectively cleaning the teeth, surgery may be needed. There are varying degrees of treatment, ranging from the reshaping of the gums alone, when bone loss is minimal, to fully involved gum surgery, in which the bone around the teeth is reshaped. Sometimes grafts of bone, gum tissue, or both may be placed. These procedures involve suturing, periodontal packs, or even both in concert with the surgery. Lastly, maintenance therapies help ensure that full-blown periodontal disease does not recur. Naturally, professional dental care alone doesn't cure the disease. The patient is ultimately responsible through proper home care and by returning to the dental office for follow-up visits. The particular treatments chosen by the doctor for individual patients vary, depending on skill and training. The bacteria population in the mouth, both good and bad types, is quite complex. Treatment is directed at restoring this balance, using whatever the dentist feels will work, whether it's surgery, at-home patient treatments, chemicals, or any combination of these. Always emphasize to the patients that periodontal disease is much like diabetes. Once you've got it, you're predisposed to having it for life. Only careful attention to warding off active disease prevents it from happening all over again. Understanding periodontal treatments first demands an understanding of the disease process itself. Both the treatments and the disease occur in a series of many steps, the most important one being the step the patient is going through that very moment. Periodontal disease occurs in increasingly severe stages. First, when there's no bone involvement, it's generally termed gingivitis. Gingia, meaning of the gums, and itis, meaning inflammation. So gingivitis is simply inflammation of the gum tissues. Anytime more than 24 hours goes by without the teeth being brushed and flossed, a condition of gingivitis can set in. This state is called acute gingivitis, since it's temporary and eliminated completely when regular daily home care is restored. 4 things present at the same time cause dental disease: time, teeth, sugar, and bacteria. If you remove any one of these, the disease stops. Naturally, regular removal of the bacteria is the easiest means to control the disease. Persistent inattention to proper oral hygiene can result in marginal gingivitis, where the margins or the edges of the gums are reddened and puffy from disease. Again, this condition is totally reversible by the patient through daily flossing and brushing. Chronic gingivitis may begin within 2 weeks of inadequate home care, depending on the patient's health. It borders on more severe forms of periodontal disease and is defined by some as periodontal disease without bone damage. Treatments for gingivitis involve detailed home care instruction, sometimes using special flosses and holders, brushes, and/or chemicals. And professional cleanings are needed to eliminate rough surfaces that trap bacteria. Finally, some patients may need additional help through prescription-strength fluorides, antibacterial rinses, or other prescription medicines. Periodontitis, perio meaning about or around, dont indicating teeth, and itis again meaning inflammation. Periodontitis is defined as inflammation of the structures around and supporting the teeth. The range of disease is infinite, but certain degrees have been defined. While no single clinical classification for the different periodontal diseases exists, we might rank seriousness from 1 to 5, ranging from 1 being simple inflammation of the gums with minimal bleeding, to 5 implying necrotic bone tissue, including bone loss. We've considered gingivitis. Let's look at periodontal disease's 3 levels of severity. Mild periodontitis generally involves teeth that have 5 mm pockets or less, with some bleeding present. They may be movable side to side in their sockets, but generally less than 1 millimeter, which is normal. X-rays reveal minimal bone loss. Mild periodontitis may be corrected without surgery. Root planing and curettage usually imparts a cure if coupled with the patient's judicious home care. Afterward, regular maintenance treatments are needed to monitor healing, the patient's cleaning efforts, and any possible recurrence of disease. Moderate periodontitis generally describes a condition where the teeth have pockets of 5 to 7 millimeters. Significant bleeding may be present, and the teeth may be mobile up to 2 millimeters side to side. Bone loss is significant. Moderate periodontal disease must be treated with a combination of surgical and non-surgical care. Some offices precede surgery with non-surgical root planing and curettage, and others combine both. Even more rigorous home care is expected and demanded of the patient. In addition, the need for prescription medicines is increased. The follow-up maintenance visits will be more frequent due to the compromised situation of the existing teeth, bone, and gums. And finally, severe periodontitis results in an almost unpredictable treatment outcome. Probings exceed 7 millimeters, often being so deep that the periodontal probe disappears into the pocket. Pus may be present. Bleeding will be profuse. The teeth may be so mobile that not only do they move side to side by 3 millimeters or more, but you may also be able to actually depress them into the socket. The bone damage can be so extensive that many teeth will ultimately be lost no matter what you do for them. As such, it's hard to explain the expected results to the patient. Treating the severest forms of periodontitis involves more than periodontal surgery alone. Often, endodontics, special restorative care, oral surgery, and other dental procedures are needed as well. Home care for the patient is extremely demanding. Special cleaning aids, even including tufted pipe cleaners, may be needed. Throughout a patient's periodontal treatment, no matter what a patient's degree of disease is, every step is critically important. As we've said so many times in the other films, that the most important step is the one that's being done now. If it's one that's your responsibility, your involvement in the patient's healing may be as great as the doctor's surgery or even the patient's home care. Preventing disease is always easier than treating it. The dental hygienist's role centers on this goal of prevention. Your duties as a dental assistant may also involve assisting the dental hygienist. The process of the dental prophylaxis, or preventive cleaning procedure, is a lot like the root planing procedure discussed in a few minutes, only instrumentation is directed above or just below the gum line. For this procedure, the materials gathered for root planing and curettage usually also work for the prophylaxis, except that anesthesia is rarely needed. We'll discuss the instruments in detail shortly. If years of neglect have passed and a full course of periodontal treatment is needed and delivered again, some patients may think twice about having the surgery. Some treatments may be that dramatic, which reflects the drama of the disease itself. These are our reminders to encourage us to do whatever we can to motivate patients into regular cleanings, checkups, and proper daily home care. The usual personal protective equipment is used and worn during patient care. As mentioned at other times, there are no enhanced levels of sterility required during periodontal treatments. All dental procedures demand absolute sterile techniques and close attention to high levels of disinfection of the treatment area. The earliest stages of periodontal disease may be corrected non-surgically through closed tissue curettage. This procedure, which involves gently removing the diseased tissue from the inner surface of the gingiva, is usually performed in conjunction with root planing. Whether assisting the dentist or the dental hygienist, your role in root planing and curettage is to improve the treatment's efficiency by passing the proper instruments as requested. More important, though, is your role in keeping the operating field and instruments clean so that the dentist or hygienist can see to the proper care. Sometimes root planing and curettage can be performed for a patient without local anesthesia. Often only a topical is needed and used. If a local anesthetic is administered, the proper materials must be available for the dentists. Some doctors prefer an anesthetic with a higher concentration of vasoconstrictor, say 1 to 50,000 epinephrine instead of 1 to 100,000. This better helps control hemorrhage during treatment. After walking through the various non-surgical and surgical procedures for the different degrees of periodontal disease, we'll back up and look more closely at the individual instruments described and used. Once patient care is begun, as a scaler or curette is returned to you after each use, it'll need cleaning for reuse. Some offices use dips of antiseptic solutions. The operator may also need to wipe the instrument's tip periodically during its use. Alcohol-soaked gauzes make good wipes. A thick compress of gauze soaked in alcohol is very safe and effective. Maintaining a clean and aseptic field during treatment is very important for optimal patient healing. A surgical aspirator tip is very effective at removing small pieces of tissue from the area or the instrument tips. It's also quieter and kinder to the delicate gingival tissues. If ultrasonic instrumentation is used, high-volume evacuation will probably be needed to remove the large quantities of water needed to keep the instrument and the teeth cool. Your role may also involve sharpening the instruments. Considering both the expense of the items and the importance of it being done properly to minimize patient treatment time, proper technique of sharpening is critical and is beyond the scope of this program. Make sure of your technique before proceeding, having someone already skilled at it show you how it's done. Always use a sterile Arkansas sharpening stone after the instruments have been sterilized, and keep the stone available during treatment should it be needed. Or consider using an automatic honing machine. They are almost fail-safe and restore dull curettes and scalers to near surgical sharpness. After teeth are scaled smooth, the minute scratches left must be polished away. Compare this process to sanding wood. Rough sandpapers are first used to remove the bulk of old paint or rough wood, and finer sandpapers help leave a warm, soft, smooth wood texture. The operator usually has a preference in prophy polishes or pastes, which come in fine, medium, and coarse grits, and even more flavors, and some have fluoride in them as well.